So again, welcome to our Project Echo Dementia on March 24th. And hope everyone is doing well. Our usual format here, we'll do some opening notes and reminders. I don't know, we could do introductions. We've got a small enough group today, or we just kind of roll right into it. And then we have a fantastic didactic around genetic neurodegenerative diseases with our own Sumi Jayadev. Dr. Jayadev, thank you for joining us. And a couple of reminders, if you are in a setting with multiple attendees, if you could put the names of the folks that are with you into the chat, that way we keep track of who's here for CME and other purposes. We'll encourage you to mute your microphone when we're not speaking, and please do say your name when you unmute. If you have the bandwidth and capacity, it'd be great to have a video on, but if you can't, understand that too. Just a few reminders about other adjacent ECHO and training efforts, including the TBI, Behavioral Health ECHO, Psychiatry and Addictions, Telebehavioral Health, so lots of other things to consider, knowing that your time is valuable, your brains are full. Also some pain management support, a tricky topic, and nice to have some consultation and other conference options. Oops. We don't have a case, but when we do talk about clinical things, just a reminder to protect PHI. Also a reminder that if there are sessions that you've missed or want to go back and revisit, they are all on our website, as will this one be. And then, of course, we'll have a quick 1-minute post-session survey afterwards. We've got our didactics codified up through June 9th. We are busy putting together the rest of the calendar year and have some great things planned. We'd love to get any feedback or input if you have other topics you'd like to see. We also truly value cases. It's some of the best part of this experience learning, but also open to suggestions. If there's something that would make it less of a heavy lift, we're happy to think flexibly about how to best present cases. So if you have ideas or wishes, reach out to us. We are accredited for CME. We have no disclosures that are relevant today. There's a mitigation process whenever that does occur. If you ever perceive otherwise, please do let us know also, either in the survey or reach out to either Dr. Eisenberg or I directly, or Elsa. Same for nursing. Here's our team. Here's all of you in various places around our great state of Washington. We've updated our stats. We've crested 1,000 hours of instructional time based on the number of attendees and number of sessions. We've had about 140 different people join these sessions over the years. And boy, what a continued kind of excellent community we have out there with tons of different expertise and backgrounds. Speaking of which, I will turn it over to our expert neurogenetics colleague, Dr. Jayadev, professor of neurology and a valued team member in the Memory and Brain Wellness Center, as well as other clinics around the UW. So I'll stop sharing and turn it over to you.
Thank you, Chris. Okay, let's see if I can do that now. And all right, are we good with this?
Perfect.
Great. All right. So thank you, Chris. And yeah, I'm at the University of Washington. So what I wanted to do is take the time I had to touch on a few topics, because I figure it'll be interactive and we can talk about what matters most to you folks or what you're most interested in. By way of background, so I do attend the memory clinic half day a month with the genetic counselor to see patients that are considered to be high likelihood or higher likelihood of having genetic diseases. Otherwise, our genetics clinic is at the university site, and we have clinic once a week. There are at least there's 4 providers there that see various genetic diseases, and 3 genetic counselors who also see patients with us. And next year will be 50 years of the neurogenetics clinic that was started by Tom Bird then, which is amazing. So you can imagine we also then have the experience of having seen multiple generations from the same family. So These on the left are some of the major diseases that we see, which I'm sure you could guess, but just to give you a sense of what it is, Huntington's disease is maybe 30% or so of all of our diseases, and then there are some other movement disorders and neuropathies and ALS. So what I'll talk about today is I'll talk about Huntington's disease, then I'll talk about genetic testing and dementia and what my thoughts are about that. And then last, I'd like to just discuss genetic testing and genetic counseling, and then we can go from there. And I'm perfectly happy if you want to ask questions in, real time. So let me talk about Huntington's disease. And the reason why I want to talk about it is this. So as you know, so it's an autosomal dominant disease. It's generally adult onset. There are rare juvenile cases. Well, maybe not that rare, but there are juvenile cases. It invariably leads to earlier death than otherwise. And occasionally there can be an expansion of the gene mutation so that in younger generations, they have an earlier age of onset. And the prevalence is thought to be around 10 to 100,000 in the Western world. There are region-specific prevalences. So the symptoms of Huntington's disease are really, there's three major features. So one is the motor feature, and that's the chorea, which is the involuntary movements. There can also be ballistic movements, so really quick arm, leg movements, head. Patients can develop a dystonia, or not a dystonia, but they develop dystonic posturing. And so that's when you sometimes see them leaned over to one side or a little holding their arm in a certain position. They have motor impersistence, and so this really gets in the way of their gait stability, and what that means is they lose tone very quickly. And if you've seen any of the Huntington's docs do an exam, maybe when you were training, one of the ways in which we test that is by having them stick their tongue out. If you have motor impersistence, you can't maintain your tongue protruded for a long period of time. But anyway, it's an important feature to add in addition to the chorea, because the chorea we can treat medically or pharmacologically. The motor impersistence we can't treat pharmacologically, so it becomes a real problem for safety. They have impaired saccades, and so not only do they have difficulty initiating saccades, their saccades are slow, and so this gets in the way, as you can imagine, of say driving, being able to quickly see your peripheral vision, and to the point where as the disease progresses, they really are moving their head to saccade to look. And they can also have impaired breathing, and they generally will develop dysphagia, and often it's the choking that is the final clinical straw. The cognitive features of Huntington's are also quite impairing. So in general, it's an executive dysfunction. They have difficulty with judgment, difficulty with multitasking. And you can imagine then, it's not an obvious memory dysfunction. So they appear, so they don't appear necessarily demented to someone who sees them, say, at work, but they start to make a lot of mistakes at work. And importantly, because they have lack of insight, they do not necessarily realize they're having problems at work. So sometimes what happens is that they're having problems and they just get fired because they don't realize they're having symptoms. They haven't talked to their boss about it. They can also have disinhibition, and importantly, they have difficulty learning new things, which again comes into play at work. It comes into play when going into disability and being, telling disability they can't do their certain job, but they also can't learn a new, more manual, low intensity job. They just can't learn new skills. They have difficulty with concentration, and they can also have apathy. And the apathy, again, so the apathy becomes important to identify because it's that usual depression versus apathy type of distinction. And we can treat the depression and can't necessarily treat the apathy. And last, there's a psychiatric piece of Huntington's, and that tends to be one of the most problematic aspects of the disease. So there's depression, which we generally can treat with the drugs that we would treat in the general population, but then they can also have severe anxiety. They can have obsessive compulsive behaviors, and they can get so agitated that they can have outbursts, including violent outbursts, verbal outbursts. And so Often we have pretty good luck if we try something like Depakote for the violent outbursts. Antipsychotics are also useful for the lability, as well as even some of the more rare psychotic features. And the good thing is those neuroleptics are useful not only for the psychiatric piece, but also for the movement, the chorea. And rarely there can be hallucinations, but often there can be delusions. So this whole spectrum of symptoms and signs just makes for a very complicated patient to manage. And so, for instance, at our center, we have a social worker and a nurse and multiple physicians, and that's how we try to make things work, which is still very difficult. I'll just mention this really quickly, but just to refresh you if it's been a while, the mutation in Huntington's disease is a repeat of CAG nucleotides, which encodes a glutamine codon or glutamine amino acid. And so the mutation results in a larger protein and a larger piece of RNA. And we don't know why. I mean, we don't know why that causes disease. That's the take home. But we do know that the repeat number can give us a clue about the chances of developing symptoms, and really grossly the timing of it. So normally we all have between 10 and 26 CAG repeats in the Huntington gene. That's normal. And then the size of repeat that results in obvious disease is 40 CAG repeats and above. And so if you see in Huntington's patients, they most likely have 40 and above. The juvenile cases have about 60 and above. And there is a really gross correlation of age of onset and the repeat size. So with the higher repeat size, there's a lower age of onset, and then that the age of onset gets older and older as the repeat size gets smaller and smaller. Patients often ask then, well, I have 43 repeats, so when am I going to develop the disease? And at that point, we always say, impossible to know, because while there is a curve, there is huge variability even at the same CAG number. So that correlation works for huge population. It doesn't work on a patient to patient, like on a prediction at a prediction level. There are these low penetrance alleles, 36 to 39, and so these alleles can sometimes cause a Huntington's disease, but then there are plenty of people that go on to late in life and never develop the disease. So it's a decreased penetrance. We don't really know what are all the factors that make people eventually present or not. Just anecdotally, we've had a few people with 36 to 39 that did develop symptoms earlier, and they tended to be the ones that had more of the rock and roll lifestyle. There's also possibly genetic variants that can influence that. So there's some new work going on trying to look at the CAG repeat itself, and if there is a change in that sequence at some point, there's a higher chance of patients developing symptoms. So there are a number of reasons why patients can develop disease, even if they have one of these low penetrance alleles. And then there's this, which I doubt you will see really, which is just this range of CAG repeats where they will never develop symptoms, but there's just a slightly higher chance that this repeat length will expand into something more. So, there are many challenges to Huntington's disease, and if any of you have seen folks with HD and want to talk about those, I'm very happy to do that. So, so first of all, it's just it's a triple threat of movement, psychiatric, and cognitive dysfunction, and because it is adult onset, not late in life, it affects people at their most productive time. Generally, these people are not only working, but they're supporting a family. And so when they have to think about going on disability, or they have to be told, look, it's time to pull back, it comes with a whole slew of issues as far as the implications to the family. It can be very difficult to manage behavioral symptoms. I think that's one of the biggest problems we have often, especially if patients have to then be placed in adult family home or nursing homes, trying to work with staff to think about non-pharmacological approaches to, say, agitation. And then there are unfortunately some folks, especially the younger folks we've had, that have such severe psychiatric disease, and we've gone through all of the psychiatric meds, and it's just been, they're just recalcitrant psychotic features. It's been very difficult. There are also legal issues sometimes. Sometimes it's being charged with assault or this or that, and we have to explain that one contributing factor may or may not be that they have Huntington's. But anyway, but it can be, there's legal issues to the patient, but also they sometimes have to think about getting divorced, and they need to think about how they're going to set up their estate for later. And then the social work needs are immense. And so it's really critical to have social work involved in these cases. So if you have HD patients and you'd like to have them seen with us, we are a Center of Excellence housed at the UW, and we see people in person. I'm also happy to see people over telemedicine. We're trying to physically get back out to Yakima and Spokane, where we used to go once or twice a year. I'm not sure if that's going to happen, but we can definitely do telemedicine visits, especially in collaboration with their primary neurologist. So I'm happy to work with you and just discuss the case, and give you our thoughts and whatever support for resources, et cetera, that we can. Okay, so any questions on the Huntington's piece? Okay, so I did want to touch on this concept of genetic testing for dementia, because, for a lot of reasons, it's become more of a topic. Not only are we finding out more about genetics and dementia, finding out more risk genes that have a high likelihood of causing disease, but also there's always that discussion in the research realm about trying to find genetic risk factors, et cetera. And then patients, hear about all this on NPR or wherever. And so they also have gotten to be quite knowledgeable about this concept. And so it's not infrequent that we have people just ask about genetic testing because they know it exists. So I wanted to tell you my thoughts about when we think about genetic testing for dementia. And I should also tell you why. So as far as the dementing illnesses, if it's Alzheimer's disease, if it's early onset Alzheimer's disease and it's familial, it's important to do genetic testing. Familial frontotemporal dementia, and then frontotemporal dementia with motor neuron disease. These three, I think, warrant a discussion with the family where you can bring up and say, hey, are you interested in doing genetic testing, because there is a higher likelihood that this may be genetic compared to other types of diseases. I did want to point out, these are a little out of order. I did want to point out, though, why we even think about this. And that's because single gene Alzheimer's disease is exceedingly rare, and also exceedingly rare, even if you look at people that have an early age of onset. And so this is a kind of a complicated color picture, but here's all Alzheimer's disease. Of all Alzheimer's disease, maybe about 25% or less than that is early onset AD. That's what the light blue is. Of the early onset AD, only a small percentage of that is actually familial. So, or autosomal dominant, I should say. There are other families that have early onset disease that probably are multifactorial, but of the early onset, only a small percentage are true autosomal dominant. And then of that autosomal dominant, we only know about the cause and some small percent of it. So all that to say that even when we think we've got a case that is most likely genetic, we still often don't find the cause. And to get to that question, a number of years ago, to get to the question of how often you'd find it, we had funding to do exome sequencing, so the entire exome, on a patient cohort. And what we did was we recruited individuals from the memory clinic who had either early age of onset, so less than 60, or had multiple family members, at least one of whom had early onset. And so those people, you would think, okay, they must have a genetic cause. And there are two pieces to that. One is they must have a genetic cause. Are we going to find the genes that we know are associated with Alzheimer's disease? And just to remind you, the three genes that we know associated with autosomal dominant Alzheimer's disease are presenilin 1, presenilin 2, and APP. So the thought was, well, now that we can test, because before that it was extremely expensive to test for these 3 genes. Now that we can test, we're going to test this 50 people or 100 people and look to see how often we find those mutations. And when we did that, we only found about 5% of individuals that have early onset, less than 60, had a mutation, and 2 of those were questionable. The next question was, well, okay, so you didn't find any of these known presenilin gene mutations. There must be something else that you're going to find, because it's so unusual to have such an early age of onset. And it turns out we really didn't find much. We did find some risk variants in genes like TREM2 and SORL1, but we really don't know what to make of that. So all of that to say that even in early onset, the yield is fairly low. So this is one way you could think about genetic testing. So if you have early onset familial AD and familial FTD, I do think it's worth just mentioning to the family, hey, this could be genetic. Are you interested in talking more about it? Because they may not know, and it may have implications for their children. So it's it's useful to tell them. If there are other families that look like they're multiple generations of a movement disorder or early onset Parkinson's disease, again, that's something you could say, you have this family history. Are you interested in learning more? And then there are the cases that are, really more case specific. So FTD, frontotemporal dementia with motor neuron disease, it would be reasonable to talk to them about it. And people that have AD less than 60, like I said, it's not high likelihood you'll find something, but if in your discussions they ask you about it or they seem interested, you could let them know that it is a possibility. And then if you have Alzheimer's disease onset greater than 60, even with 2 or more relatives, I think the yield is very low. So there are different ways you can do this. So, and there's a real, we really have a low number of genetic counselors right now across the country. So it's unfortunately kind of limited, even as our need goes up. So there are different ways that you could approach this if you wanted to refer them to us, or if you wanted to give me a call or send me an email and discuss whether or not you'd want to send them to us. I've seen this happen, and I could give you more information if it's for some reason difficult to see us, or you'd rather, you don't necessarily want to send them to us, but want to give them information about genetic testing. There are online services for genetic counseling, and I've seen that done once, and it was a reasonable experience. So people don't have to come up to Seattle if they don't want to come. This is an example of the type of panel testing that we do. And so nowadays, it used to be like $3,000 for one test. So now you can spend maybe $1,500 and get a number of genes at the same time. So this is an example of a dementia panel with ALS genes, because there is overlap. And then there are different types of panels. So and I'd say one thing to always remember is that if you have a dementia case, it's reasonable to do one of these dementia panels, but also we always need to remember the C9orf72 gene, which will not be on one of these exome panels. You have to make sure that you look for testing, a separate test. And frontotemporal dementia is a little bit different because there is it's more likely than Alzheimer's disease to have a genetic cause. And so this is just sort of an estimate of the genetic contribution. And so here is like all FTD. In patients that have sporadic FTD with no known family history, supposedly less than 10% have an identifiable gene. So that's like if you know the family history and it's negative, then there's a less than 10% chance you'll find a gene. However, if you have some family history of something, Parkinsonism or some kind of neurodegenerative disease, then maybe a quarter of them would have some type of FTD gene or a gene that's contributing to their FTD picture. But about 10 to 15% of FTD actually have a true family history of FTD itself, and those folks were more successful at finding the causative gene. And then lastly, I wanted to talk about genetic testing. And so there are options for testing. One is doing single gene testing. So like, for instance, MAPT associated with FTD. It's some of the mutations are just single point mutations, and you can just send for a single gene testing, and that is maybe $1,000 or so. And then, like I said, the C9orf72 gene testing has to be done separately, and that's because the mutation in this gene, and this gene causes frontotemporal dementia and ALS, and frontotemporal dementia ALS. And as we learn more, probably a number of other phenotypes, but that's the main description of the clinical features associated with that gene. The nature of the mutation is such that it can't be done with typical sequencing methods, and so it needs to have a special test. Something that we use more often are gene panels, and that's because for the same price, you can get a number of genes. And then the problem becomes trying not to get a panel that has far more genes that you're interested in, because invariably you will get a variant of unknown significance. And so let's say you're doing a test for muscular dystrophy. You might find a gene mutation that's already been reported in the literature that's clearly associated with limb-girdle muscular dystrophy, that is rare in the general population, and it seems, okay, that must be pathogenic. But very often, if not every single time, there are variants that are reported, but it is unclear if they mean anything. And so they may be, say, predicted to cause some effect on the protein when they do the computer modeling, and yet it turns out to be present in the population, 0.01%, higher than you'd expect. You might find that other family members may have the same variant, but yet they don't have the disease. And so it becomes more complicated. So you really want to tailor your panel to the disease and ideally the genes that you want. And last, there's whole exome sequencing, which a lot of people in genetics, that can be done, I would say, after gene panels are done. And then, and sometimes there can be, you can find disease-associated variants, and that also becomes very complicated too, because you will find more variants. But there are a list of genes that you can discuss with patients, where it's a list of genes that are known to change medical management, and so no matter what you're testing for, the labs can test those 56 genes, and then patients can opt in and decide, yeah, I want to hear about it. Even though you're testing me for dementia, I want to know if you find a cardiomyopathy gene, and you can give them that information. Oh, I had more. Okay. So what do we want from genetic testing? So as docs, we want the diagnosis. We want to know if there is a change in the treatment, and it just, we're just sort of curious. We want to understand the disease. And then from the patient standpoint, they often have other, they have different drivers. They also want to know what they have. But often, we have patients that say that I want to get this testing because I really want to get the right treatment, or I'm really sick of living like this and I want something better. And that disconnect between what we can give from genetic testing and what they're hoping is something we always have to, resolve. But aside from management, they often want to do it for the sake of their kids and for the sake of planning. But important to know is that many individuals, and I would say actually in case of Huntington's disease, more often than not, individuals who are at risk for inheriting the gene do not want to get tested, which was a surprising thing to me when I first started doing this, but that's the case. So issues that the patients really should think about, and these are topics that the genetic counselor will discuss with them in pre-test counseling. So how would this test influence my relationship with my partner, with my friends and family? Does my mother have the same disease and she doesn't want to get tested? So do I have to think about what I'm going to tell her or not tell her? What are my coping strategies? I've always had this problem with anxiety and depression. And when I was in high school, I almost tried to commit suicide. And so do I have everything in place right now? And it is now the good time. That's often a question that we discuss with people. Is now the right time, especially because right now in the neurodegenerative world, we don't have any interventions. And we certainly don't have interventions for people who are pre-symptomatic. So it's not even like they should get tested in order to start drugs. So the question is now a good time? What else do you need to put in place before you get the testing? And so who is my support network? Should I get a therapist in line? And then think about how is this at all going to change my career plans or not? And importantly, what kind of financial planning should be done prior to testing? This is really important. So there is the GINA Act, which protects people that have a genetic diagnosis, without an asymptomatic genetic diagnosis. They just have gene testing. GINA protects them at work and for health insurance. You can't be denied either because you just have this gene mutation. However, long-term disability and life insurance are not protected by the GINA Act. So once a patient has that gene test result in their chart, even if they don't have any symptoms, they can be denied long-term disability and they can be denied life insurance. So because of that, what we do during pre-test counseling is to tell people about this. And many times people first go get those insurance plans in place and then proceed with the testing. And then if the test is negative, they drop it. They drop the insurance. And again, it's important to help patients think through what are the implications to the family and there isn't a change to their medical management. So genetic counselors, for you to know, they get a master's degree in genetic counseling. They also do, they have practicals, they have research projects, and they are an extremely important aspect of genetic testing because they really are the ones that take the patient down that route of, well, what's going to happen if you test? What are your drivers for testing? What's the realistic expectation for doing testing? And then that person then becomes the point person, the counselor for everyone in the family, and they can serve to support sort of in a cascading effect of genetic counseling support. Yeah, so this is what I was talking about. We don't have a lot of genetic counselors, but there are other services that we could help find for you if you can't, if you don't have one, or if patient can't get up here, or if it's just too late. I mean, not too late, but it takes a long time. We do have a wait list that we're trying to trim down. And so we do really excited about this. The UW now does have its own genetic counseling program. So hopefully we're going to at least make a difference in the local area, or at least Washington, if we can get some GCs trained up and start to, go beyond just being at UW and OHSU, et cetera. So that's what I had for the formal discussion. This is my email, which I imagine you could post somewhere, email me anytime. And then here's the clinic manager if you ever wanted to make a referral. Okay, so I should stop share.
Jimmy, thank you for that excellent overview. I'm curious, questions. I see one question in the chat from Nadine, and I don't know, Nadine, if you're able to unmute and ask that, or if you want me to read it. I can read it for you. So a question of, multiple family members had dementia. No problem. Had dementia at or after 65, 5 sisters. Should their offspring get tested? The 5 sisters also had vascular risks, so not clear if it was really Alzheimer's disease.
That's a great question. It's such a key question. And so the easy answer would be, well, let's look at the clinical records of the sisters, and is there any of the sisters available for testing? And so if that was the case, we would first do any of the sisters. If there was an autopsy tissue on any of the sisters, we would do testing on the sisters. In the absence of any of that, for the offspring, I would say no, because we wouldn't know what we're testing. We wouldn't be able to interpret the result of the tests. So not at this time. Now, someone like that, though, is welcome to say, get in touch with the Alzheimer's Research Center, because that's the kind of person that we would, possibly follow, or at least keep in touch with, because there are, like I said, gene variants that are associated with a higher risk for Alzheimer's disease, and we'll see that in a family. And so there may be people that are doing research studies with family history such as that. So yeah, that's what I would say. Why only early onset dementia? Seems like in many cases, people have MCI and dementia 5 to 10 years before they ever get an actual diagnosis. Are we missing many families who could benefit from genetic testing? That's an excellent question. And I would say, well, so early onset, I would say it's early onset cognitive symptoms. I mean, certainly if someone has had cognitive symptoms, you know, at 50, but didn't get diagnosed until 60, that I would still consider that early onset. But so it's a way for us to distinguish between people that have onset, say at 62 or 65. But I don't, you know, there have been a lot of studies that have done genetic testing on cohorts of people that have earlier age of onset, even less than 65. Because in the field, it's early onset 60 or 65. And still the yield has been sort of low. So I think the yield is going to be low, but it's a reasonable question. And it's important to make sure we have a good handle on when the actual symptoms were. Yeah, so Nadine, all of those folks are dead. So if you'd like to tell the patient that she can contact the Alzheimer's Center in case there's anything else that may be of value, she can, but they wouldn't be doing genetic testing. So if she's doing that for genetic testing, they would be doing that.
I was gonna say, Barack, I've seen you mute, unmute, mute, unmute. You've got a question you'd like to ask.
Yeah, so thanks so much, Sumi. That was great. You know, so I'll just like ask you the question that I'm sure all of us get every day. You know, so you know, my mother developed dementia at 70. What does that mean for me?
Yeah, absolutely.
Yeah, so that, I mean, that's the elephant that is in the room every day.
Yeah.
Somebody asks you that, what do you say?
Yeah, so we say, yes, there is a slightly increased chance of you developing Alzheimer's disease. We know that from large population studies. There were a number of studies done more than a decade ago looking at groups that had that were divvied up on whether or not they had the ApoE4 allele, and then whether or not they had one affected parent or first degree relative or two, and there clearly is a slight increase in their risk for Alzheimer's disease. We had actually done a study at the UW on patients that had two parents with Alzheimer's disease, all late onset. And again, that showed an increased chance of Alzheimer's disease. So by the time people were 80, there was, I think at least 80% had, or maybe 80% had Alzheimer's disease. I don't remember the number now, but yes, there is an increased chance. But overall, it's not, you know, doesn't reach 50% risk. And there is nothing that we would do genetic testing for, even if your dad had Alzheimer's disease. I think that's we are learning a lot more about the huge list of genes that may be involved in contributing to the risk, which is many. Another question, an 88-year young patient asked me about genetic testing for Parkinson's. Her son was diagnosed and her granddaughter carries the gene. Do you recommend testing and which ones? I would say for the 88-year-old, I don't know if it's for her clinical management. I'd say no. I wonder what. I suppose it matters what the gene was, and when her son had onset. I mean, there are rare forms of autosomal dominant Parkinson's, but that may not be what her son's talking about. A GBA1. Yeah, I don't. Yeah, of course. It's a risk factor. I don't think it's any value to her testing. I don't think it'll give her much information.
The psychologist in me wonders why an 88-year-old would want to know this. she feeling
Curious
like,
about
right, guilty, like this is my fault, or you know,
Mm,
curious, right?
that's a great, yeah. And that's a true entity, the feeling of guilt from the parent. Yeah.
I see Dr. DeMotta Riley has a question.
Yes, thanks for the great talk, Sumi. Yeah, wondering then about kind of related to this, like blood banking.
Yes.
If somebody's not ready to, family doesn't want to know right now, but there's somebody that's symptomatic, could you talk about that as a possible option?
Yes, thank you. That's really, really important because there are plenty of people that are kind of on the fence. They don't necessarily want to know because it's going to be sort of they don't want to know for themselves. They either have the disease and they don't want to deal with it. They're afraid of testing, but they want to have that ability for their kids to know at some point. So what they can do is bank their DNA. So it's a blood sample. It now gets sent to a place called Prevention Genetics, and they just store it. And so, and I've done this myself. So you take the blood, you store it, and then years later, you can go have it tested again. So it's useful not only for people that aren't sure if they want to know, but also, yeah, you know, if there is a family history, but like, you know, ALS, but all the tests have been negative, you can store that DNA, and at least, you know, I mean, the researchers might be doing their own testing, but at least, you know, as a family that you can always go back and have it tested clinically for any new genes that come about. So I think it's a really valuable option for sure. Yeah, it's blood banking.
Although I guess there's a cost, a yearly cost.
Yes,
then.
there is a cost. So I know at least it costs, well, I don't know, you might, I don't know if you know more, but it's at least 250 to start. And I don't know what it is yearly. We used to do it for free at Children's, but now it's a service. So I'm not sure about that. But a great option.
Related to that, what happens, you know, if the person isn't wanting to get tested yet, but their children really want to, if the person passes away, like, is there an avenue at which the family members would be able to test that, even if the patient didn't want to know that information themselves?
Yeah. So this has come up, and when the child wants to get testing, I mean, child as in the adult child wants to get testing and the parent doesn't, you know, the child can still get his testing, and then it's sort of up to them to work out how they're going to manage that challenge. That's happened more than once in our clinic. But if the parent did not want to get testing, did not bank anything, then there isn't, you know, there's no way to kind of force them to do it. There have been rare occasions where we have gone ahead and tested the offspring only because we knew that we knew exactly what the phenotype of the parent was. We knew that it was familial because there are multiple affected family members. And so, and the patient herself was a doc who understood the implications of a variant of unknown significance versus a true pathogenic variant. So it seemed like she would be okay with getting those results. And so we did that. But otherwise, there have been a number of times where we've said we just can't test anything in particular. I don't know if that gets to
Is there anything about if a person passed away but had banked it, would the family have any
yeah.
authority to say?
Right. No, it's just so strange. No, they do have the authority. I think it's in the same way that you would have the authority to go look at the medical records. They can have that tested. Yeah. Is that Allison?
Yes, Allison chiming in. I found it really interesting, this idea of the blood that could be tested at a later date. In our case, we have my husband's brain tissue at UCSF. And so it seems like that's also an option to be able to go back and say, okay, there was no known genetic markers in 2014, but what are there now?
Right. Yeah. So, and the way that would work is tissue just gets more complicated because you have to have someone process it to get the DNA, but always, you know, in an academic center, there's probably a way that you can work with that team and have it sent off. And we have sent off, I think Kimmy probably, we've sent off for people that have passed to get clinical testing. Yeah.
Thank you.
Yeah.
Good, excellent questions and comments. Other thoughts, questions? I'm wondering, you might have addressed this, I got distracted for a second, but how has 23andMe complicated your life in terms of, the person who walks into your office and says, I have this ApoE4 allele, what does this mean?
I didn't discuss it. I avoided it, and then you brought it back.
Yes.
So thank you. Yeah, so that's been, it's been interesting. So just to let you know, folks, we don't test for ApoE in the clinic because, and that's the standard across neurology, because there is no, it can't be used prognostically. So for people that are unaffected, we don't test. We don't know what we would say, so we don't do it. So, but yes, people go do their 23andMe and they find out they're ApoE4. And just from a systems level, we've tried to figure out how we're going to manage that because for a while, it's kind of tailed off a little bit. For a while, we were getting a lot of those questions. Well, now what do I do? I've gotten this testing. What do I do? And our genetic counselor had met with a number of people for a while, and we basically just said, we don't know. But people do come in with that. They come in actually with GBA variants or LRK variants pretty often. And we just have to try and reinforce that we can't predict. These are risk factors like any other risk factor you might have, and that we just continue to learn more. I don't think it helps people to do 23andMe. So if people ever ask, I say don't bother. But yeah, it's interesting. And I've had someone wish that she didn't hear about it. And somehow she got 23andMe and hadn't intended to get ApoE testing. I don't know if there's a checkbox or something. And so she wished she felt that it negatively impacted her, which was unfortunate. And so, there are interventions that are being aimed at ApoE, and it looks like, if ApoE is so ubiquitous, it probably affects everything you look at. But there are drugs that may be eventually targeted at the ApoE4 allele, and so eventually it might become useful to know it, but not right now.
I think I would ask Kimmy this also. Do I understand correctly that ApoE raises your risk for ARIA with the monoclonal antibody treatments, right? An E4 allele increases risk for complications.
Right. So in terms of interventions, we may be very soon coming to a point where knowing your E4 status would affect treatment. But I guess, then to go further on that, Sumi, would you feel that if somebody knew their E4 status from 23andMe, how much do we trust that? Should we still repeat that testing to know for sure, again, to direct their treatment?
Yeah, great. Thanks for asking that too, because yes, the 23andMe method of genotyping is different than we would do it in the lab. And so, in fact, it's kind of hard to get ApoE genotyping. So we always would do it in a clinical lab, which is more accurate than the 23andMe approach. So, yeah. Yeah. Has anyone had any Huntington's people?
Only the ones that you've sent.
That's been really valuable to have the neuropsychologists weigh in on Huntington's folks, because probably a lot like Kimmy's frontotemporal dementia folks, they can appear quite appropriate, interactive, and then there's some aberrant behavior that sort of is sort of surprising. And so it's useful to have the neuropsych testing to demonstrate, okay, there really is some executive dysfunction or whatever it is. So.
Yeah, I'm mystified at how difficult the disability process is for somebody with, a known neurogenetic condition.
Yeah, it's really unfortunate. So, yeah. Well, I am available anytime. If people want to talk further, have any questions or looking for resources, etc. Very glad to have met all of you all over the state.
Thank you again for this wonderful talk and for your generosity of availability. And as we don't have a case,
Yeah.
I'm curious, if anybody has any pressing clinical issues or revisiting topics or cases from prior sessions. You got everyone figured out and buttoned up and got a survey. Go. Well, we could take a vote. We could give you the gift of time on this busy Friday. We could think about future topics. Barack, you've got something?
Yeah, I mean, I was, as we were kind of thinking about today, I mean, I saw a patient this morning that I could sort of share about. It's not necessarily like there's a huge diagnostic dilemma or even management dilemma.
Barack, no case is too small or big.
Yeah.
So please do.
Yeah, and I mean, and this is sort of somewhat apropos to the talk that Sumi just gave about just how hard it is with Huntington's patients who are sort of kind of at the prime of their life, which is so the patient who I saw this morning was a follow-up of a 66-year-old man who has just like a very, very high profile, intense sort of leadership kind of job, and has just in the past year been more clear that it's a diagnosis of Alzheimer's disease, and and in some ways he feels like he's functioning just fine, but then people around him are clearly raising flags that he's not, and so it was like a kind of an intense sort of visit of really helping him to see that there's like still so much that he can do and should do in the many years that he has to come to contribute, but that handing off that sort of being in the hot seat of responsibility, both for his work activities and his own personal finances, will improve his quality of life going forward. And so that was kind of an intense conversation we had this morning.
No, absolutely. You think about two things there. One is that environment is likely, partially what reveals those early deficits, right? Those demands. So the height of those, the complexity of those, and then how much, I don't know this person, but how much meaning and purpose and identity gets wrapped up in that, and how hard it is to step away, even though it may not be the healthiest thing for you.
Yeah, and I remembered something that you sort of told me before, Chris, which is like helping people to think about and actually, and so this was actually the analogy that I sort of gave to him this morning, which is that like think of your kind of like your life's work as being this like wonderful, beautiful thing that you're like holding in your hand, and just like what a important and good thing it would be to sort of like gently hand it over to somebody and sort of let them sort of like keep this like beautiful thing that you have created, rather than to like stumble and trip and have it sort of like come crashing to the floor and sort of break into lots of pieces. And so then I think that he kind of heard that, and that was like I think that made sense to him.
Yeah, important to preserve that legacy, right? Well, I suspect that'll be an ongoing conversation. I wonder how that will unfold over time. I thought of this group, or on Tuesday, my neuropsych eval was a young, healthy woman who went in for a total hip replacement and came out apparently in the mid stages, but she had postoperative delirium, encephalopathy due to medications, which improved a little bit, but she is not well in terms of her cognitive functioning. Looks like she's maybe in the mid stages, somewhere between the early to mid stages of Alzheimer's disease. And the most interesting part of the story was her husband adamant that she had 0 symptoms before the surgery, and there were no complications. She didn't get anoxic or have any cardiac events. And few, episodes of forgetting words every once in a while, but 0 concerns from him. And that's always puzzling. So I went back through the medical record, and at her 2018 Medicare annual wellness visit, which included the mini cog, she had 3 out of 3 words and a normal clock. In 2020, at her annual wellness visit, she had an abnormal mini cog. So she had 2 out of 3 words and an abnormal clock. The primary care provider made note of that and said we should follow up on this. Never got followed up on. Pandemic probably interfered, whatever. But then she went in for the surgery in 2021. So there was this little hint of something potentially going on that was then unmasked, I think, by this procedure. And it really kind of drove home this importance of these opportunities that we have to detect things, and how hard it is sometimes to get people back in for a more thorough assessment. And now there's this question, gosh, what happened to her? But it made me think of all the great work, in primary care settings to improve that, either pre-surgical screening or detection opportunities, and how to make sure we have systems in place to follow up when something is questionable. Well, hearing no other comments or questions, we can adjourn a couple of minutes early. Yep. Always appreciated in terms of your participation and feedback about how to make this a better series. So maybe we'll bring. Go ahead.
I'll just so like the suggestion for lecanemab presentation. I think that that story is still sort of unfolding, and so I would just put in a plug for us to revisit that topic in 3 months, 6 months.
Absolutely. Yep. Absolutely. I think that that's wise as we look at what this might mean. All right. Well, we will add that to the list. And if you have ideas about who you'd like to see present that, we're open to that too.
Somebody with no financial conflicts.
Yes, absolutely. Absolutely. All right. Well, with that, I will wish you a wonderful Friday, and we'll see you. Oh, we have one more announcement here. So our next session on April 10th. Here we go. That is going to be with Michelle Sheff, a speech and language pathologist, around speech and language challenges and treatments in dementia. So an update on a prior talk from at least well over a year and a half ago. So look forward to that on April 10th.
April 14th. April 14th.
April 14th. I missed another detail there. You'll get a reminder email, I promise. But yes, I can correct it real time. All right, April 14th. And with that, we'll see you then.